bunion's a foot deformity that is typically progressive throughout life. So typically babies are not born with bunions. They develop later in life. Some people develop it early in life, and that just means that they have a very severe form of it versus the typical presentation is it's present for many years, many decades, and then gradually, progressively gets to the point to where it becomes symptomatic to the point to where they seek care. It very strongly congenital. It tends to run strongly in certain families. People with a more flexible foot type tend to be more prevalent in developing bunions. Flat foot is also related to bunion deformity, so many times those two things will be presenting at the same time. Females 2-to-1 dominate over males with regards to the development of bunion deformities, and that probably has mostly to do with their flexibility. The symptoms are highly unpredictable with when they develop. Many of my patients will state that the bunion stays the same for a long period of time and then progresses rather rapidly over the period of a few months and becomes much more symptomatic quickly. So a bunion is not a growth of a bone, it is more of a malpositioning of a bone. The bunion is essentially the bone malpositioning itself on a basis of getting wider in the forefoot. So people typically try to address it by wearing wider shoes in the beginning because the bone is shifting slowly, gradually outward, and the bunion in the forefoot is getting wider and wider. Then there's a secondary component to that. When the bunion becomes big enough, then the big toe shifts and points the other direction. And then patients many times will get issues of rubbing between the big toe and the second toe. They start to overlap. They start to develop hammer toes because of the bunion. And that's where the progression of the deformity, there's obviously a mild version, there's a moderate version, and then there's the severe version. And if you allow it to happen, it will progress through all those phases of development. Obviously, the shoe gear choice has a large degree effect with regards to the degree of symptoms that the patient has as well. So I don't like to use the term cause, but definitely it can be an aggravating factor. Shoe gear choice, high-heeled shoes that put you more onto the ball of your foot can aggravate it. Pointy-toed shoes that push the toes together can aggravate the symptoms. And just the width of the shoe, of course, is a big issue with regards to bunions, and that's one of the first things people notice is that they, all of a sudden, there's certain shoes in their closet they can no longer wear. And many times my patients, when they present, they're down to their last few pairs of shoes, and sometimes they can't even wear closed-toed shoes. They can only wear sandals or Crocs or loose-fitting shoe gear where there's a lot of room in the toe box. There's all sorts of information out there with regards to bunion splints and different techniques in order to correct the deformity without surgical intervention. It is possible that you can manipulate people's joints and you can make things move and shift. And bunions are no different than anything else. If you catch it early and it's small enough and you're flexible enough, you can sometimes fight against the progression of the bunion. I've never witnessed people reverse it or fix the problem. And the problem with splinting techniques is that realistically I've met anybody who's willing to splint their toes the rest of their life to avoid the progression of a bunion. So while it is possible, I don't find it to be a real practical option for people that are seeking actual correction. Typically, we have to x-ray the patient to assess the degree of the bunion and what type of potential complications they're having secondary to the bunion. So the degree of the bunion has a large effect with regards to the ability to get symptomatic resolution. Specifically conservatively, really, if you can, early on, of course, people with wider shoes and orthotics and anti-inflammatory medications and even using splints or gel pads or cushions to alleviate pressure pains and avoid rubbing or irritation between toes Those are the simple, easy things that most people have tried before they even come to my office. By the time they see me, they've already become either frustrated or failed those techniques. And so most of the time we're really discussing surgical intervention. As this is a structural deformity, the only way you can probably truly expect resolution is to change the structure. And that can only truly be achieved through surgical interventions. The way I like to word it to my patients is it's kind of a surgical fracture. So we cut and we realign bones, and then we reposition them in a place that corrects the deformity, and then the bones have to heal themselves just like they would heal a fracture. And we fixate it to hold it in place while it heals, and we have people wear protective boots and special shoe gear postoperatively to help protect them while they heal up. And then once the bone is healed, it's forever in a different place or location. So it's a structural change to the shape of the bone and the shape of the joint. So in younger patients, we tend to be more aggressive because we are concerned more about rebound or recurrence of the deformity later in life. And that's always a potential for patients, and it's up to the surgeon to do everything we can to try to help avoid recurrence. That's where procedural choice comes into play, and we have gotten much better in the last 20, 30 years at doing procedures which are aggressive enough to actually fix the deformity and maintain the correction long term.